Top Med Talk.
This is Top Med Talk, the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. The EBPOM World Congress is taking place this year between the 7th and the 9th of July at the British Library in London. Check out ebpom.org now.
Well, hello and welcome to Top Med Talk here at Anesthesiology 2025. It's the annual meeting of the American Society of Anesthesiologists. I'm Desiree Chappell, your host and co-editor-in-chief, and we have had a fabulous trip here over the last 3 days. It's day 3 of the meeting, and we have had some wonderful conversations. So if you missed out on any of those, be sure to check them out on topmedtalk.com. You can hear from our wonderful guests over the last 3 days, so do check that out. I am really excited about this next conversation, dialogue that we have had here on Top Med Talk for many, many years, but it's specifically focused around patient-centered monitoring outcomes and how we really are moving to this space where we believe, and this is the general, I think, we in consensus, that we should have continuous monitoring for all, really. So it is with great privilege and pleasure that I introduce two fan faves, I do have to say, for Top Med Talk. We have Professor Michael Scott from University of Rochester, New York, join us. Hello, Mike.
Hi, Desiree. I think this is the first time I've joined you since taking up the chair position at University.
I was going to tell you congratulations on your...
So thank you for that.
Yeah, fantastic. And we have Dr. Wael Saasouh, is a colleague of mine. Many of our listeners know that I'm also vice president of NorthStar Anesthesia, so I wear lots of hats. Wael and I are partners in crime, really, for research within NorthStar. So he's our director of research. Wael, thanks for joining us.
Of course. I'm Wael Saasouh. I'm an anesthesiologist with Wayne State University at the Detroit Medical Center, and I'm the director of research for NorthStar Anesthesia.
Yeah, fantastic. Well, and Mike, you've worn many hats over the years and done a lot of work in different spaces, but I wanted to talk and start this conversation out with, I say recent, it feels maybe a little bit not as recent anymore, but it's still getting a lot of traction, was a consensus paper that was done in collaboration with the Anesthesia Patient Safety Foundation on continuous monitoring for patients and hemodynamic instability. Can you tell us a little bit more about that paper?
Yeah, that's right. We had a conference in Philadelphia a couple of years ago to try and get consensus, not with what to do at the bedside, but how to change patient outcomes. So looking at both health payers, CMS, the American College of Surgeons, ASA, everyone had representation. And this is really trying to deliver a system-level fix to deliver the optimal monitoring for patients. And really, it's about the right monitoring for the right patient at the right time. And the reason I'm passionate about it is obviously I've been very heavily involved in ERAS, and I think we've done very well there. But the one thing in clinical practice that still doesn't seem to be great in our delivery is hemodynamic management. And to me, the reason it's important is that we can see now with the data coming out that there's these enormous downstream implications if you don't do hemodynamic monitoring well. We see the short-term things of a bump in creatinine, a little bit of delirium, gut dysfunction, and then leading to SSI. But we now know, both from my paper from AKI and also other papers coming out now which are following in non-cardiac surgery, that any complication which is to do with perfusion of the body has a marked downstream impact on your 1-year mortality. And yet you have a patient in the PACU and you can't really tell the difference. So it's a silent killer, basically. And that's why I'm sort of focused on that.
Yeah. And I think in one of the papers, you even said the impact on 1-year mortality, but even beyond that, AKI leading to chronic renal failure later on. And really, so even it's the immediate impact, but it truly can impact the longevity of our patients. And
that's right. And obviously, you've got the different stages of AKI. You've got renal reserve, which is key in basically the trajectory of the patient. But we know that doing good hemodynamic monitoring, we can reduce the severity of the AKI, and that's important because the more severe the AKI, the worse you do downstream.
Yeah. So while we've talked about this a lot, and I've heard it more than I have in my career, is the idea that we monitor vital signs continuously. So oxygen saturation, end-tidal CO2, EKG, heart rate, all those things. We don't do that with blood pressure. And Dan Stessler has told us here on Top Med Talk that when you monitor blood pressure every 3 to 5 minutes, you're missing at least 50% of hypotension. So we have talked about this. So this truly is an issue for us.
It is an issue, and it's the positive end of it is that we are actually hearing more about it. So this past year has seen a lot more interest in a topic that was considered to be dated just last year or 2 years ago. People thought that we knew everything we wanted to know, which is not true. And when we start talking about patient outcomes and the short-term and the long-term impact, it's not just our patient. It's the patient and the family and the society and the community and the cost and the healthcare system as a whole and the population. So this is not limited to somebody's low blood pressure in PACU and we gave them something to help. This is way beyond. So I think the onus is on us to figure out what we can figure out. And we previously used to say we don't know what we don't know because we don't have the data.
Now we have the
And once we have it, the more we know about it, the more we can treat it. And I'm glad to see so much interest in it.
I wanted to back up just a little bit in this evolving story. We go way back on enhanced recovery and utilizing goal-directed fluid therapy and focusing on fluids. And then with Dan Sessler's paper in 2015 and highlighting the impact of intraoperative hypotension, we started focusing on that. Mike, you and I, well, actually all of us have had conversations about the fact that maybe it's not the blood pressure that's the problem. It's more of the hemodynamic instability piece. And I don't know if everybody is quite grasping that yet. What are your thoughts on it?
Yeah, there's been quite a story here, and I feel partly responsible with the ERA Society talking about restrictive fluid therapy. But this has been misinterpreted by surgeons. It was always intravenous salt and water fluid restriction. So I get the IV down day one. It was never about intraoperative fluid restriction. We've never published that in any guideline. But now I go into the OR and some of the surgeons say, don't give more than 2 liters of fluid. And it just doesn't make sense. And that's why Dan Cole and I, Dan is the president of APSF, we labeled the white paper hemodynamic instability because it isn't just about blood pressure. It's full flow pressure. You've got to have the right volume before you squeeze. And we're seeing all these unintended consequences of people just using vasopressors now. And there's 2 very good multi-center studies and systematic analysis to show that. So the problem is blood pressure is easy to measure, but flow isn't.
Right.
But there is now on the horizon all these non-invasive monitors, which is becoming really quite exciting, really.
Yeah. And they look at more the hemodynamic profile of individual patients.
Yeah. And really, I think we're going back to the term perfusion because perfusion isn't just pressure, it's also flow.
Right. And for a while, we felt like we were handling the problem well because all we had was a blood pressure measurement at the bedside. So when you give the pressor, the number looks better. And then we think that we're good. And we're not doing this long-term monitoring, which now we almost have no excuse to not do it. And now we're going to start seeing the downstream effects of mismanagement in the acute phase. And I think we have a lot of opportunities to improve.
Yeah. So we're looking at, we always talk about changing the standards of monitoring. So we're still talking about the desire, I think, of the greater community to change the standards for continuous blood pressure monitoring. What are your thoughts on that? Like, I can see we want continuous blood pressure, but we don't want to focus on blood pressure, right?
Yeah, I think when you look at clinical practice, if you have an arterial line in, you've got total situational awareness of your patient with the arterial waveform. But obviously, not everyone should get an arterial line.
Right.
So if we can get an alternative and see beat-to-beat blood pressure and then also be able to derive the fluid responsiveness from stroke volume or stroke volume variability, which is a very good way if you ventilated at 8 mils per kilo of predicting fluid responsiveness, it really gets most patients in the right ballpark before we then use the pressors, because obviously it is important to maintain the map as well. And if you ask every single anesthesiologist here at ASA that if you could have a continuous arterial waveform trace giving you all these values and it isn't an arterial line, then you would use it because it just makes life a lot easier.
Yeah, for sure.
And when we talk about continuous blood pressure monitoring, by the time that becomes a standard, which is hopefully soon, I understand the limitations. Once we have that, there's not a single monitor out there that does non-invasive continuous blood pressure monitoring that does only blood pressures. So by then, all of these monitors will have standard features of showing you a whole slew of things. And we're not just monitoring blood pressure, but if that's the title we're giving it, I think it's okay because we will be getting all the monitors on just because the blood pressure is part of the device.
I have maybe an existential question. I think we've asked this on Top Men Talk before, but we talk about the duty of candor and talking to our patients about the risk associated with surgery. And we talk about kind of stroke, MI, and things like that. But we are seeing the impact of outcomes of hypotension and mismanagement of hemodynamics. Do you think we need to be talking more to our patients about this?
Well, yeah, and we did cover this in the white paper, because if you think informed consent from a surgical perspective is telling people about complications.
Yeah.
And the complications can be only about 1 or 2%. And yet we've got this whole sort of area where we're getting AKI rates of anything up to 15%, depending on the surgery types, which has a downstream effect. And yet we're not actually consenting people to the fact we might be robbing a bit of their kidney function if we don't do something properly. I mean, obviously some AKI is unavoidable. You get the primary and secondary. But there's no doubt that when you look at the studies like Fedora and Impress, if you do fill flow pressure and just optimize your flow and bump your MAP above 65 with very low dose pressors, you get far better outcomes and problems start dissolving away.
And give a little squeeze, a little bit of contractility. Absolutely. Too, that people sometimes forget about. I always say our ephedrine got locked up in much of the United States for a while because of the methamphetamine crisis, and people stopped giving in the inotrope.
I think that's a good point, because I mean, if you look at a lot of studies now in the US, I mean, there's no ASA 1-2 patients really having your age of ephedrine on. And so the sweet spot is less, and the ejection fraction is less. And so we are seeing more need for some sort of beta, which I think is why everyone's going for norepinephrine in major surgery over phenylephrine. And obviously now, I think over 60% of ORs can give peripheral norepinephrine in the USA. And when I wrote the review article in ANA about, I think it was 8 years ago now, it was the exception to the rule. So I'm very pleased to see that that's changing.
Yeah, I think you've moved the needle on that one a little bit, Mike.
And we talk about patient outcomes and how much we should disclose to patients and what kind of conversation we should have with them. Based on work we've done, I know for a fact that patients want to know.
Yeah, you've published some studies on that.
We have, and it's continuous work, and we're trying to gather more insights. But by the data and thousands of patients, 90% of people want to know all of these details. They want to know daily updates on everything that's happening, whether it's associated with risk or not. So if you have a few low blood pressure measurements, we brush it off. We think it's fine, but they want to know. They want to know. And everybody is in this health consciousness phase. Everybody wants portable monitors. Everybody wants to know their own numbers.
Cool.
So there should be no difference in a hospital setting, especially in an operative setting where a lot of acute changes are happening.
So while I'm in academic practice, you're in private practice, what do you think the key changes, differences are, and what do we each need to focus on?
That's an excellent question. We also know from prior work that we've done that hypotension is available. It's there in academic and in non-academic settings. And then it's roughly the same. So when we talk about the E-pre-op 31 measure and we talk about 65 millimeters of mercury MAP for 15 cumulative minutes, it's roughly
about the same.
It's about 30%.
Looking at academic practices versus community.
These are not small studies. These are major academic centers, and this is community-wide non-academic centers. So we're all in the same boat, technically. And we've noticed that a big determinant of what happens with hemodynamics is the clinician treating the patient. And if we can, as a first step, at least just raise awareness on a general population level to say, this is actually a problem. You don't see all of it. You see only part of it. I think people will organically take ownership of the process. Nobody is willing to harm patients. Everybody wants to do the best they can, but they don't know all the details.
Yeah. And we had a wonderful Ravenstein lecture this morning by Sachin Kirtapal, who's developed MPOG.
The multi-center perioperative outcomes group for this.
Yeah, and the data from that is really compelling, isn't it?
Well, then that was going to be part of my next question is, how do we get buy-in for doing continuous monitoring, looking beyond just the typical vital signs that we've been using and risk stratifying our patients? Because, we've been beating the enhanced recovery drum for a very long time. And I can tell you, I know that there is market penetration. We see that in a lot of sites. There are still a lot of sites that don't do enhanced recovery. So where do you think, Mike, what's going to move the needle for us on?
I think there's many things. I mean, the white paper that we wrote was all to do with the sticks and the carrots health system level. I think we're facing, it's a bit like pulse oximetry when it came out. It was not available to everyone. We knew it worked. It was hard to publish even studies to show changes in outcomes, but because really you were intervening sooner.
Much like
the interesting thing is we have got the data on hypotension.
Yep.
We do know continuous is better than intermittent. And we now probably know that the continuous finger cuffs are more accurate than arm cuff intermittent.
Yeah.
There's a sizing in the... And the number of times I go in to the OR and people are just still pressing the inflate button. Whereas really, I think what we need to be doing is giving some ephedrine. Rather than keep crushing the cuff, it's probably that the blood pressure's low and it's not picking up.
You could just do this.
And that's where the continuous will help. It's chicken and egg. And the problem is I don't know if manufacturers can manufacture it cheap enough at the moment to get it into practice across the whole of the USA. I think you can buy a $20 oximeter off Amazon now, which fulfills FDA requirements. We need that sort of market and technology to really change this. You've got wearables that you get your blood pressure, heart rate, and everything on your watch now. So, it is about technology and introducing it. And I think once people start using it, there'll be no looking back.
That's been my experience.
What do you think in private? How do you think you'll get this in?
If this is available and accessible to people will use it. Developing this technology is expensive, and the companies that are developing the devices will need to recover their cost. But we have to get to a point where everybody and anybody can use it. And like you said, it would be a no-brainer at that point, because why wouldn't you use it?
Yeah. I think for me, in the work that I do in the quality space, still backing up even further, just to say, we really, truly do have a problem. And though, each one of us want to believe that I don't, Desiree Chappell, I'm great. And I'm very proud of the clinical practice that I have and how I take care of my patients. But being realistic with, I really can impact the further on downstream, like you said, Mike. So to me, I'm still in that education phase of we do have a problem. For sure. Well, a lot of the work, Mike, that you've done over the years, and specifically on the APSF, was focused in the U.S., but you also do so much international work too, and international collaboration. I just wanted to touch on that for just a moment, because I know this is very important.
Yeah, well, I was involved in the World Health Organization Lifeboat project. I'm very pleased to say that University of Rochester residents have raised the most money here. So we're number one to the list.
Round of applause.
But all the residents at UMC, thank you very much for doing that. And yes, as you know, the Eras Trail took me
all over the world,
banging the drum, collaboration, going, well, do you want to talk about it?
Yeah.
Sure.
Your alma mater.
My alma mater,
That's
what I call my original anesthesia training, was at the American University of Beirut in Lebanon. And I was just there last week, actually, talking about intraoperative hypertension and collaborative research. And there's real opportunity to gather minds from different parts of the world to tackle the same problem that everybody has. And when you start thinking about a problem from multiple angles, you start getting creative with a solution. And it provides opportunity to all of us, really, to be more productive and to enhance our academic output, especially in countries where the skill is there, but there's no accessibility to some of the resources that we have. So I think it's only a natural pairing that can go on from there. And I'm glad to see that you also, Rochester,
education and opportunity. I've got a faculty member who trained with you, and I've now got a resident as well, and hopefully a fellow exchange on the way. So we're very excited about that.
Well, I'm also heading the research fellowship, and we have fellows from all over the world, including Lebanon. And it's really heartwarming to see how much drive there is out there to work on solutions and to get things out there.
Whenever you can bring minds from all over, the expansion in thought that we can have, we're much better together and coming together, especially for people that come from under-resourced areas and have to be a little bit more creative. It brings this whole other line of thought into how we solve problems. So I think it is a wonderful example of this collaboration and how we move things forward. So any parting thoughts, Mike? You have a microphone here in front of you, and we all hang on your words. What is Mike Scott thinking now? Where are we going?
The key thing is we still know that you can get roughly in the right ballpark with hemodynamics, with fill flow pressure.
That's your mantra. I tell everyone that I lecture to.
The figures out there really, you've got to drop about 10 mils per kilo at the start to overcome the anesthesia and positive pressure ventilation, and then you give boluses to target. And you do end up positive flow balance on post-operative day one. And 20 to 30 mils per kilo, you're going to be absolutely fine. You don't want to be 6 litres over, though, and you just want to get that IV salt and water down. And meanwhile, then the finesse is using the monitors intraoperatively, particularly with these ASC 3-4 patients and difficult surgeries with blood loss and fluid shifts. And then we're looking more now, we've just done a POCI in extended recovery, or EPAC as we're now calling. And it's very similar to the model we had in Guildford, where you run 3-to-1 nursing you basically focus on with transthoracic echo and continuous flow monitoring, insulin and early enteral feeding and mobility. So you're not losing the ERAS components, but you're making sure you're fixing the circulation. And then the post-operative day one, you take all the drips and drains out, feed them breakfast and walk them to the floor. And that seems to halve complications overall. And there's more and more evidence with Guy Ludbrook's group and international consortiums going on now to try and introduce this into clinical practice. I mean, to me, I think this is the next step. I think it's ERAS hemodynamics or
that's a good way.
However we want to term it. But I do think we're entering a new age where we can truly take that next step and improve patient outcomes, not just looking at length of stay, but downstream longevity and reduction in complications.
Yeah, that's great. We actually had a fabulous conversation with Guy earlier about what he had coined originally as ARC, or Advanced Recovery Room Care, and now we're rebranding through the Perioperative Quality Initiative, the EPOC, Enhanced Postoperative Care Unit. And so keep an eye on this space, right? Yeah. All right. Gentlemen, thank you so much. It is always such a pleasure to talk to both of you and hear what's new in this space here. Thank you for listening to Top Med Talk. You can always find us at topmedtalk.com. We are on your favorite social media platform, your favorite podcatcher. If you find us there, give us a thumbs up, give us a rating. Let us know what you want to hear more of. We always love feedback from you all. And we want to thank the ASA, the American Society of Anesthesiologists, for giving us this beautiful booth. And of course, our sponsors that we would not be here. We would not be able to keep Top Med Talk free and open access to the world without the generous support of BD, APM, or Advanced Patient Monitoring, as well as GE Healthcare. Thanks everyone for listening. Cheers.
Top Med Talk.
Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. Join clinicians from around the world at EBPOM World Congress 2026 between the 7th and the 9th of July at the British Library in London. 3 days of evidence-based perioperative medicine, global insights and expert debate, featuring speakers including Michael Marmot and Ken Rockwood. Go now to ebpom.org. That's ebpom.org.